On, I think it was question 23 where we had to match with the phrase.
Yep.
It said 2 left sides. I think that it was supposed to be left shoulder and left
Yeah,
side.
I saw that. Did you get that one wrong?
Yeah.
Okay. Yeah, we're going to
Yeah.
talk about that.
Yeah, I think I did too.
All right. I think I'm going to go ahead and give credit for that one because of the typo on that one. Is that okay with everybody?
Yeah.
Yeah.
All right, so we're going to give that. So, where do you guys think that it should be? Let's go through that question, okay? Just so we know it. White on right should be where?
Right shoulder.
Right shoulder. Black and white should be?
Left
Right
shoulder.
side. Left shoulder.
Yep. Smoke over fire is?
Left side.
Left side.
Snow over grass.
Right side.
Okay, and then the brown?
Fourth and fifth intercostal space.
Right. Okay, so I'm going to give credit for that one, okay? All right, girls. Let's get started. Any other questions on the test? No? How about we do this? Let's go through the test. So make sure we know them, okay? So, blank is the period during which a heart chamber is contracting and blood is being ejected, okay? That should have been systole, okay? This is true and false. Blood pressure is the result of cardiac output and peripheral vascular resistance. And that should be true. Number 3, at the end of ventricle diastole, both atria simultaneously contract to eject 10 to 30% more blood in the ventricles. This is known as?
Atrial fibrillation.
Right. On an ECG, what is the first negative deflection seen after the P wave?
Q.
Q. Okay. Hey, Meredith, do me a favor. Mute your phone for just a second, or whatever you're using. Let me see if it's still giving kick. It's still giving kickback. Never mind. It's not you. All right. The intrinsic rate of the SA node is how many beats?
60 to
100.
60 to 100. Okay. On the ECG, the T wave represents, so it's either ventricle repolarization, ventricle contraction, atrial repulsation, or atrial contraction.
Ventricle repolarization.
Yep. All right. And then you had to complete the chart. So lead 1 should be where?
on the side. The left side of the patient.
I'll tell you what, we're going to go over the lead here in a second. I'm going to skip this one, okay? Because we're going to go through that here in a second. Causes of artifacts included loose electrodes, broken wires, muscle tremors, patient movement, external chest compressions, and 60 cycle interference. Okay. The ECG leads that show the horizontal plane are V1 through V6. When preparing a patient for EKG, you should ask them to empty their bladder, and then to turn off any devices, any electronic devices.
Wait,
right.
do we have a test on Thursday too?
No, next Tuesday.
Okay.
All right, and then in which of the following locations should you place the V5? Okay, and it's at the anterior axillary line at the same horizontal level as V4.
Same as before.
Yeah. What of the cardiac conduction initiates the heartbeat? You guys remember that one?
The SA node.
SA node. Yeah. And then this was which waveform on ECG would indicate a MI, a myocardial infarction, and it was the ST segment elevation. If you're caring for a patient with ventricular tachycardia and they become unresponsive, you're going to start CPR. You guys hear me?
Barely.
Yeah, I'm hearing a lot of feedback. All right, Emily, let's test your phone. All right, I think that was it. We may have to mute for just a little bit, okay? And then you can unmute if you need to come in. Is that better, girls?
Yeah.
Okay. How should you clean the equipment? You're going to use a soft cloth moistened with disinfectant or an alcohol-based substance, okay? There's a P wave, but no QRS. You should report this to the nurse right away. Your patient goes into a systole. What should you do first? Remember that was the dead, right? Start CPR. The speed of the paper is measured in millimeters per second. When you are working with the paper of the EKG, you're going to thread the paper through the roller to the outside of the machine. And I already said this one, make sure you tell them to empty their bladder before you start the EKG. So if somebody has left ventricular heart failure, you would see edema, pulmonary edema. A normal EKG pattern is as follows: a positive P wave, negative Q wave, positive R wave, negative S wave, and a positive T wave. Okay, so this was about the pattern. If one does not fire, the other one's going to take over. And I put SA node first, AV node, bundle of His, left-right bundle, and then the purging fibers, and that was true. And then I'm going to throw out question. I'm going to give everybody credit for question 25 because there was a typo on there. I saw that right away. All right, let's move on. All right, so let me get my PowerPoint up here. You can see the PowerPoint, right? Yes? Let me get this here. All right, girls, let's start. So what I'm going to do today is kind of review some stuff that we've already done, okay? And then I'll add some more stuff from like chapter 9. But this is going to pretty much kind of review everything about ECGs, okay? And then we're going to take another test on next Tuesday, and then we're going to be done with that for now, okay? Then I'm going to hit hard for the next few weeks using the manual, the NHA manual, okay? And we're going to literally go back through patient care and break it down. We're going to go back through infection control and break it down. And we're going to go. So everything we kind of learned in PCT 101 also, we're going to break it down so that you guys are ready for that test. Okay? All right. So let's start. I can get it to work. Okay. So again, you know, I keep harping on this right here as far as knowing knowing the vital signs. It's really important, guys, because that's one of the main things you're going to be involved in. So let's make sure that we kind of know these, okay? Let me move you guys over a little bit. Okay, so this is kind of my little synopsis of basic anatomy, okay? So the heart is the size of a person's closed fist usually. The heart has 4 chambers, the right atrium, right ventricle, and left ventricle. The wall between the atria is the interatrial septum. The wall between the ventricles is the intraventricular septum, okay? Then we already learned about the 4 layers. So on page 120 in your manual, let's see here. Let's just kind of look through that because you do need to know all those. Because I'm sure on your, not necessarily always on my exams, but the exam for PCT will have to know some of this stuff. So on 120, it talks about the different layers, okay? So your pericardium is the sac that encloses the heart, okay? So it's the one that's right around the heart. The epicardium is the outermost layer of the heart and the innermost layer of the pericardium. The myocardium is the middle layer. And the endocardium is the inner layer that lines the chambers of the heart and forms the surface of the valves. Okay, so make sure you make a note to kind of review page 120 and the heart layers. Okay, now the valves, they control the direction of blood flow through the heart. Okay, so if we didn't have valves, that blood would go back and forth between the heart and there wouldn't be anything making it go in one direction. So the valve's job is more or less to keep the blood flowing through the heart, okay, and not back flowing. And then again on 121, it lists the different valves, okay. So let's look at those. So your tricuspid valve separates the right atrium from the right ventricle. And yes, there will probably be some of these on the test, okay. The bicuspid or the mitral valve separates the left atrium from the left ventricle. The pulmonary valve, it lies between the right ventricle and the pulmonary artery. And then the aortic valve lies between the left ventricle and the aorta. Okay? All right, so those are the valves.
Are we allowed to write in these books?
Yeah, they're yours. Write all over them. I write them on all the time.
Okay.
Yeah. All right, so here's your first question. Which heart valve separates the right atrium from the right ventricle? So let's type in, please, your answer. Okay, so which heart valve separates the right atrium from the right ventricle? It's the tricuspid. Okay, tricuspid. Okay, so circulation. I wish I could move this over a little bit. All right. So the circulation, let's just talk about this. I'm going to go kind of broke it down real easy. So the right atrium receives deoxygenated blood from the inferior and superior vena cava. The right atrium pumps blood through the tricuspid valve into the right ventricle. The right ventricle pumps blood through the pulmonary valve to the pulmonary arteries, then to the capillary bed of the lungs so that it can get oxygen. Okay? The pulmonary veins then take the oxygenated blood to the left atrium. Excuse me. Okay, so here the left atrium pumps the oxygenated blood through the mitral valve into the left ventricle. And then the left ventricle pumps the blood through the semilunar valve to the aorta. And then the aorta delivers the oxygenated blood not only to the whole body, but to the heart itself. Okay? So that is actually kind of on page 121 if you want to make note too about it. But that's kind of what the whole circulation system does. Okay. So parts of the heart are on page, well, I guess I don't have, yeah, I do, page 122. And I'm not going to go into detail too much about that. But just review the vessels, like the coronary artery, the main left and right main arteries, and the ascending and descending of that. So make sure you look on 122 and look at those. Okay. Now, of course, the SA node artery initiates electric impulses. We've talked about that a lot. And it's the main pacemaker, and it will generate 60 to 100 per minute. So we've said that before. Okay. All right. The atria well, okay. I'm going to have to do something different here. Okay, so the atria are thin-walled, low-pressure chambers. They receive blood from the systemic circulation. They normally flow from the superior and inferior vena cava. About 70% of the blood flows directly through the atria and into the ventricles, like I talked about. And when the atria contracts, an additional 30% is added to fill the ventricles, okay? So initially, we've got 70% that flows right into the atria and into the ventricles. When the atria contracts, 30% is added, right? So that makes you 100%. Now, this is that atrial kick that was on the test. This is additional contribution of blood because of the atrial contraction. It's called atrial kick, okay? Okay. All right. So this is that review real quick that we went through. All right. Here's your SA node. That's level 1, right? It initiates it. If it malfunctions, this AV node is next. Then you've got your bundle of His, your right and left bundle branches, and then down here being covered up is this Purkinje fibers. Okay. So that's just kind of a again, a review of the heart. Any questions on that? All right, so the AV node is located in the lower portion of the right atrium, which I said is right here. And then the rest of it follows, okay? The AV node's main job is to delay electrical impulse, okay? To delay the electrical impulse. It allows the atria to contract and completely fill the ventricles before the next ventricle contraction. So AV node, main job, to delay an electric impulse. The bundle of His transmits impulses from the atria to the ventricles, and it also connects the AV node with the bundles. Its pacemaker, I'm really having trouble with all this stuff. I got to keep moving. Its main thing, or its the rate is 40 to 60 beats per minute. Okay. I'm going to have to turn you guys off for a minute. Okay. The right and left bundle branch carries impulse from the bundle of His to the Purkinje fibers, causing right ventricle depolarization. The RBB receives blood from the left anterior descending artery. The LBB carries impulses from the bundle of His to the Purkinje fibers of the left ventricle, causing depolarization. The LBB divides into left anterior and fascial and the left posterior fascial. They receive oxygen from the LAD, which is right here, left anterior descending artery. Now, don't forget that the Purkinje fibers is kind of that last resort for something to fire, and it is only able to fire from 20 to 40 per minute. All right, let's go on. All right, girls, let's see if you know this one. Which delays electrical signals briefly to allow ventricles to fill completely after atrial depolarization? SA, AV, or bundle? All right, I think one of you got it right. It's the AV, okay? So the SA is the initiator, okay? The AV delays electrical signals so that all the blood can flow and before before the ventricles contract again, okay? So it's the AV node. Which initiates the heartbeat? So which is the first that it is initiated?
I was sending my answers to everyone. I'm sorry.
It's okay. All right, so that's the SA, okay? SA initiates heartbeat. AV delays. All right. Really on this one. So this is just talking about, remember that the SA node is normally the heart's pacemaker, but the AV junction may assume responsibility, right? So we talked about that before. So if the SA fails, an impulse from SA node is generated but blocked, and it exists as the SA node. The rate of discharge of the SA node is slower than the AV junction, okay? So more or less this is saying that the AV will take over. If the AV doesn't work, then you've got the bundle of His, which is a rate of 40 to 60 per minute, okay? Okay, there you go. So tell me what is the AV junction is 20 to 40. Is that true or false? False, right? So what is it, 40 to 60? Yes, no? What is it? Yes? Okay. Okay. If the ventricles function as the heart's pacemaker, they normally generate impulses at a rate of 20 to 40. So that is your Purkinje fibers, okay? So they're going to only have a capacity of 20 to 40, and we've already talked about that. Ventricle depolarization is beats and rhythms may originate from any part of the ventricles. They are characterized by your QRS complex that are normally shaped and longer than normal. Okay, so we'll talk a little bit about that. Which of the following initiates the heartbeat and acts as a primary pacemaker? Sorry about that. I got a cat and a puppy barking at each other and hissing. Whoa. Playtime. All right. So we all know that's the SA node. I can't harp on that one enough, huh? All right. So let's get moving here. Some cardiopulmonary compromise. All right. So complications can occur, girls, when you're doing an EKG. Okay. So you guys need to be ready to react. Now, if you see it, the first thing you do when you see a flat line is to look and make sure that a cable or a lead wire or electrode hasn't come loose. Okay, so it could have disconnected and then you're going to get a flat line. So make sure you check that before you start pumping on somebody's chest. Okay, we check the machine, make sure everything's connected. If not, then of course we call for help and we'll begin CPR. And these are just signs of cardiopulmonary compromise: change in color, change in their consciousness, cold hands or feet, difficulty breathing, and significant rhythm change on your EKG. Okay. Dysrhythmias, let's go to 141 and 148 in your book, in your NHA book. Okay, so I know that we were going crazy doing all of those reads, okay? But I would have you look over the ones that are listed in this manual, okay? Because this is your PCT manual that they're going to use to pull questions from. So they don't go into too much depth of it, but it's good to make sure that you look at these from 141 to 148 and get used to what they look like, because there probably will be a few of that on your PCT test. So, you know, that tachycardia on page 141, you can kind of see how that looks and get used to kind of that, maybe go over this several times. Make sure you look at like AFib and A-flutter for sure. The 143, the supraventricular tachycardia, I've seen that quite a bit on things that we've gone through. So make sure you look at that. On 144, that ventricle fibrillation, I'd make sure to know those, but just go through those so you can kind of get used to them. Okay. One thing I want to note is that 3 different P wave configurations in one lead indicates a dysrhythmia. So make a note in your notes there to know that answer. All right. Not going to get into that. Again, here's your tachycardia. See how it's just boom, 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 boom. There's not really any pretty little forms. It's just crazy. So this is what a ventricular tachycardia would look like. What do I do about it? CPR, defibrillation. Again, I'm just putting this in there so you can kind of see. We already looked at all that. I was just reviewing that. This is, again, see how it's just, there's no pretty patterns and no PQRSTs. It's just boom, 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 okay? All right. So defibrillation, I'm not going to talk too much about that. I just wanted you to, I'm trying to get out there. Oh. Let me see if I can move you guys a little bit. I guess not. It's not going to let me do it. So defibrillation is delivery of an electric current across the heart muscle over a very brief time to terminate an abnormal heart rhythm, okay? So just make sure you know that they use defibrillation to kind of put a person back into rhythm. Does that make sense? Okay. Oh, and we talked about asystole, remember that. That was the dead word, right? It's also called cardiac standstill. It's a total absence of atrial or ventricular electrical activity, okay? No pulse, no cardiac output. So it's a flat line. It's that flat line. But again, before you start CPR, make sure that everything is working on your machine. All right. So what do you do about it? We already talked about this, but I thought we'd go over it a little bit. Confirm that the patient is unresponsive and your machine is working well and has no pulse, right? Begin high quality CPR. And then the rest, the medical team will assist in giving medications and all that stuff. But you would start CPR as the answer to that. So cardiac arrest rhythms, asystole, pulseless electrical activity, ventricle fibrillation, pulseless ventricle tachycardia. So these are all cardiac, a person's going to go into a cardiac arrest if not already, okay? Cardioversion, now on your learning board, if you want to learn a little bit about cardioversion versus defibrillation, it's on there for you, but I'm not going to spend time here. Okay. Which dysrhythmia reflects the atria in a quivering state with no organized contractions? So let's go to our one, if you don't know the answer, let's go through here and kind of look at 141 to 148 and see if you can figure that one out. Look on page 142. All right, so I'll tell you what it is. It's called atrial fibrillation. So atrial fibrillation is more severe than like an atrial flutter. It's because it has no organized contraction of the atria, okay? So just remember that one. What may indicate a dysrhythmia? So we've already reviewed this early on. You've got P waves that are upright in deflection. You've got 3 different P waves configurations in one lead, or P waves that appear before a QRS complex. Okay, so let's talk about that. P waves should be in an upright position, right? They should be that nice little small hill, okay? I think we said that 3 different P wave configurations in one lead does indicate a dysrhythmia. So that would be the answer. And we are always hoping that that P wave is before the QRS, right? So it's 3. It's 3 different P wave configurations. All right, a patient goes into a systole. What action do you take first? Good job, guys. Very good. Okay, so an ECG. You're going to use an ECG to monitor a patient's heart rate. It's used to evaluate the effects of the disease or injury on a heart function, to evaluate a pacemaker, to evaluate the response of medications, to obtain a baseline recording before, during, and after a medical procedure. So if you're going in to have some minor surgery or surgery, they're going to do one before, one during, and then one after to see if you're okay. And also to evaluate signs of like an MI or injury or an infarction, okay? They can provide information about the orientation of the heart in the chest, conduction disturbances, electrical effects of medications and electrolytes, the mass of cardiac muscle, and the presence of ischemic damage. Okay, it does not provide information about the mechanical contraction condition of the myocardium, or the mechanical activity is evaluated by assessment of pulse and blood pressure. Okay, so it cannot provide information about the mechanical part. All right, so you guys already know all this stuff, but let me see if I can move this down for a second. All right, so these are what electrodes look like, okay? Of course, we know they're going to be applied to certain areas. One of the monitoring cables is attached to the electrodes. The other end is attached to the ECG machine, and the cable conducts current back to the cardiac monitor. The EKG procedure. Some electrodes contain an electrolyte gel. So when you open them, some of them already have gel on them, okay? And most likely these days that's how it is, but you may have to, may have another brand or something like that, and you may have to put some kind of gel on there, okay? So poor quality or expired electrodes or gel can cause artifacts. So we always have to watch expiration dates on things, okay? Lead wires connect to the electrodes and are usually color-coded and have letters that match the location to the place them on the body. So even though we have to learn where things go, most of these machines these days will direct you to where to put things, okay? All right, so the EKG paper, it's grid paper. Small box is 1 millimeter by 1 millimeter, okay, which equals 0.04 seconds. The large box equals 5 small boxes, which is 0.2 seconds. The standard speed, 1 second, equals 25 milliliters per second, okay? 25 is the normal speed. Now, you might have to adjust the speed. So a physician has ordered a certain speed, and they would tell you what the speed is, but you may have to adjust the machine. An example is, let's say the person's heart rate is has a very fast heart rate. So you may have to increase the machine to something like 50 milliliters per second, okay? Now, improper speed settings can result in misinterpreted dysrhythms. So you can look at it and it would actually look like a dysrhythmia, but we've not programmed it right. Okay, so it's very important to know. But the normal is right here. You always keep it on this unless it has been prescribed to go faster or slower for some other reason. Okay. Now, the standard amplitude, or it's also called the word gain, G-A-I-N, is 10 milliliters per 1 millivolt. And more or less what this does is it regulates the height of the waveform on the tracing. Okay? So, again, it's either called the standard amplitude or the gain, and this is what regulates the waves, okay? The normal is 10 milliliters per 1 millivolt. All right, now, if you're looking at the machine and you look down at the paper and all of a sudden you see this band of redness on the bottom, it's telling you that you're very close to the paper being out and you need to change it, okay? You would load with the printed side up and thread through the roller, and I can't read it because of this, and then you would perform a test run, okay? So you would load the printers with the print side up, thread it through and to the outside of the roller, and then you always perform a test run before you actually put it on a patient, okay? All right, let's see here. What is the speed measured in for EKG papers? All right, right. Millimeters per second. What regulates the height of the waveform on the tracing? You know what? Let's do something. After this one, let's start doing like 1, 2, 3, 4. I think it's going to be faster for us than waiting for everybody to type. All right, so what we got here? All right, gain. So gain is the answer for that one. All right, during a 12 lead, the patient's heart rate is 225 per minute. Now that's extremely high, right? What paper speed may be prescribed? All right, we're going to go with, well, first of all, this is normal, right? 25 is normal. So this patient is like skyrocketed. So it's probably not going to be 10 or 5. So by deduction, it would probably be 50. Okay, but that would be prescribed. That's not anything we would make a decision for. Okay, the paper is like a graph paper. Okay, it's made up of small and large lines. So it's like graph paper. Okay, we've talked already about this, but the smallest squares are 1 millimeter wide and 1 millimeter high. 5 small squares between the heavier dark black lines. Okay, and then 25 small squares within each large square. So this is just kind of showing you the breakdown. All right. When replacing EKG paper, what should you do first? Okay, so the very first thing we're going to do is D. Thread the paper through the roller to the outside of the machine. Okay, D. What is the standard paper speed of an EKG machine? $25, right? Okay, 25, standard EKG. All right, so now just cleaning the thing, okay? So we're gonna, again, we had that on the last test, but you would make sure that you're cleaning and disinfecting the lead wires, any connectors, you know, the machine that you've touched. You're gonna clean it off with some kind of isopropyl alcohol or an alcohol-based cleaner, okay? Poorly cleaned equipment and plugs can cause artifacts. If the plug doesn't fit properly into the machine, it can cause an artifact. So we have to make sure that everything aligns, okay? Now, of course, we're always going to use a minimum of 2 identifiers when you are working with the patient, and this would include things like their name, date of birth, telephone number, the last 4 digits of the Social Security number. You never ask them for their full Social Security number, okay? All right, so let's go to 128 to 129. Let me just, this is about interviewing your patient. So I do want you to look at that because you may be responsible for asking these kind of questions. So just make a note to go through there. And it talks about identifying, with the two identifiers, and then taking a social history. So you might be involved in asking them things like, do you smoke? Do you drink? Do you have a stressful life? Do you exercise? What kind of things do you eat? Do you work? That kind of stuff. The medical history might be things like, have you had a history of heart attack, stroke, blood clots, high blood pressure, heart failure, etc. Okay. Do you have things like diabetes or lung disease? Are you pregnant? Do you have any allergies, medication, food or medication, or even the environment? And then there would be a list of symptoms that would probably be on that sheet that you would ask them. You would take like surgical history. Have you had heart surgery before or any other surgeries? And then of course we want to know what kind of medications. Now, medications include vitamins and herbal supplements and things like that also, okay? So we want to make sure that we know how to do that. So you'll probably be involved in that kind of thing. All right. Now, what should you clean the machine with? We've had this one before. Good. All right. So we don't want to put acetone on it. Isn't that nail polish remover? Okay, yes. So soft cloth moistened with alcohol-based or disinfectant solution. Okay. All right. So we're going to talk real quickly about artifacts. We did this, I think, in the first week, but you guys did that on your own, so I thought we'd review it again. An artifact is a distortion of an ECG tracing, okay, by electric activity that is non-cardiac. So there's something else causing those lines to do something, okay? It can mimic various dysrhythmias, including ventricle fibrillation. The patient evaluation is essential before initiating any medical intervention, okay? So most common causes of I'm going to put this up here. Okay, so most common causes of artifacts are substances on the skin and movement. So if the person had some really heavy lotion that they used, or maybe they've had an ECG earlier that day and the sticky stuff is still all over them, and then you go and put the new one on there, it could alter it. So anything that's foreign on the skin that you haven't cleaned off really well could cause an artifact, or just movement. So the patient's moving, or maybe the patient has Parkinson's or something like that, or elderly and just shakes, whatever it might be, that can cause an artifact. But those are the most common, are substances on the skin and movement. There are other ones that we're going to go through. So here's the other ones. Loose electrodes, broken ECG cables, broken lead wires, external chest compressions. So if you're trying to do an EKG and somebody's pumping on somebody's chest, yeah, that's going to cause something. 60 cycle interference. Some internal causes are patient movement, shivering. So if the patient's freezing, you know how a lot of times those exam rooms are cold. Tense muscles, muscle tremors, like I said, in Parkinson's, or if they have the hiccups. Okay, so these can all cause artifacts. What's the most common causes? Now there's going to be more than one in this one. One. Okay, so let's look here. The most common causes are substances on the skin and movement. Okay. All right. So some special things. I'm going to kind of reduce you guys just here for a second so I can go through this. So this is special consideration. So when you're working with little kids, you want to speak in their language. Okay. Rather than calling those electrodes, you might call them stickers. And you might say, hey, this machine just kind of shows me how your heart works. Okay, so it kind of gives me a picture of your heart. You wouldn't want to get all technical with them. You want to keep them calm, right? Now, with the pediatric ECG, you have limited space because they got little chests. So you might only be putting on something like a V6 on their mid-axillary line, and they may need to move like the V3 to the right, etc. So you may have to get creative on where you are going to be able to put these things, but any kind of thing that you move that's out of normal, you would document that. So for instance, if you needed to move the V3 to the right side in the same position, you would document it as, it would be on the left, that document as V3R. Okay, so that's just an example. Now, if you've got somebody who has amputations or breast implants, you might have to also alter what you're doing. So in amputations, you're going to place the lead that would be on the arm that might be missing on the same side of the chest. Okay, or the same thing. If the leg is missing, you would place it maybe on the abdomen area of the same side. If somebody's had a mastectomy, you have to be very careful of that skin because it's very sensitive. So you would have to be very delicate with when you're putting on things. Okay. For people who have breast implants, you're going to place V1 and V2 leads higher above the implants. This would also be necessary for those women who just have larger breasts. Okay. Do not place electrodes on abdomen of pregnant women. Also, that person, a pregnant lady, may need to lie on their left side with pillows between their knees. Okay. Also consider like older folks. Remember we talked about how their skin tears very easily? When you're removing those electrodes, you need to be very careful and hold the skin down and make sure you do it very slowly. You may also need to have some adhesive removal substance to help take that off so we're not tearing their skin as we're removing those. Okay, so these are all just different, but I want you to remember that pregnant ladies, it's not a good idea to lie them flat on their backs. It helps their circulation if they're on their left side. Okay, how should you place a pregnant lady? All right. So slightly on their left side, you can prop their knees with pillows too. Okay, so let me scoot you guys over. All right, so frontal plane ECG leads. So this is the frontal plane. You've got limb leads, okay? Limb leads are lead 1, lead 2, and lead 3. Okay, so your first lead, you can see, is from hand to hand, right? Lead 2 is from right to left foot, and lead 3 is left hand to right foot. Does that make sense? But that is a frontal plane, okay? Then you've got it augmented, I don't know if you can see, yeah. Augmented limb leads. This is where you have AVR, AVL, and AVF, okay? Let's see if you can follow this in your book. I think it's in there. Yeah, so we're kind of on page 131 in your book. Okay, so AVR, let me go to the next screen. I think it'll be easier. Hold on a minute. Okay, let me tell you that. Bipolar leads, a lead that consists of a positive and negative electrode. That's what bipolar means. So most leads leads consist of a positive and a negative electrode, okay? All ECG leads are technically bipolar leads. That's what I was trying to tell you. So leads 1, 2, and 3 use 2 distinct electrodes. We'll keep going here. All right. So standard limb leads, like I already showed you, is leads 1, 2, and 3. Right arm electrode is always negative. So you need to know that. Your right arm is always negative. Your left arm or left leg is always positive. And then you're going to probably see somewhere in your exam, PCT exam, this word. So make sure you know what that is. Einthoven's triangle. Okay, so that's more or less this whole triangle with lead 1, 2, and 3. But in lead 1, 2, and 3, the right arm is always negative and the left leg is always positive. All right, so here's again the standard limb leads. Lead 1 is left arm is the positive, the right arm is the negative. And then this chart shows you that it's showing you the lateral view of the heart, okay? Lead 2.
I don't see it.
You don't see this?
No.
Are you guys not seeing it? Rebecca, are you seeing it?
I'm seeing the frontal plane ECG leads.
Oh. What happened? All right, let me find out what's happening here. Pause share. What are you seeing now?
The beginning, the cover page, PCT 102.
Oh, that's just bizarre. Why would it do that? All right, hold on a minute. Let me get you down there. Now are you seeing it?
Yeah.
All right, what are you seeing?
Standard limit.
Standard limb leads.
That was weird. Okay. It's got a mind of its own. Oh, we got to go back to slideshow. Hold on a minute. All right, you still seeing standard limb leads? Okay. All right, so what I was saying is left arm, lead 1 is left arm, and it's the positive, and the negative electrode would be on the right arm, okay? And then it gives you a lateral view of the heart. Lead 2, the positive is on the left leg, the negative is on the right arm, and it gives you an inferior view. And lead 3 is the positive is on the left leg, negative on the left arm, and it gives you an inferior view of the heart. Okay. Somehow we turned off the PowerPoint too. Huh. All right, learn this, okay? Augmented limb leads. So you've got your AVR, your AVL, and your AVF, okay? A stands for augmented. V stands for voltage. R stands for right arm. Left arm, and F is foot, usually of the left leg, it says. And my thing is acting very strange right now. Okay, so here's your limb leads for augmented. Okay, AVR, positive is in the right arm, and it says heart surface viewed none. AVL is in the left arm, and it's a lateral view, and AVF is left leg, inferior view. All right, so we're going to go over real quick the 3 leap. Generally for continuous monitoring, I have absolutely lost my mouse. The right lead is on the right shoulder or clavicle. Black lead is on the left shoulder or clavicle. Red lead is left lower abdominal area. And then you may also have that green lead, which is the right lower abdominal area. And the 5 lead, which is standard for that holster that somebody might wear for 24 hours. The white, again, the white lead is on the right sternum or clavicle. Black lead, left sternum or clavicle. Red lead, left lower thoracic area. Green, right lower thoracic area. And the brown is just below and to the right of the sternum. Okay, there's that holster. Okay, so this is something that somebody would wear. You know, they're feeling like they're having flutters, but they don't. When they go in for the EKG, they can't quite catch it. So they're going to have this guy wear this for 24 hours and see if there's something that is causing it. You know, some kind of activity. Maybe his grandkids are coming over and they're stressing him out. Whatever it might be. Okay. And there's a smaller version, which I think that's pretty cool. All right, there's your mnemonic. Remember that one, right? We did this. So I just wanted to remind you guys of that. And then when attaching, let me try, I want to do something really quick. Let me come back off here. I'm losing my mouse. Ah, there he is. Okay. All right, girls. Well, we're going to take these quizzes and it's going to show us the answers. So I don't know what happened. Can you see when attaching electrodes for a 3-lead EKG? Can you see that question? Okay. So of course, where should you put the red? So it's going to be on the left lower abdominal area. Okay. All right. So we're going to talk today now. This is where we haven't done much of this. This is the 12-lead. Okay. A standard 12-lead ECG provides views of the heart in both the frontal and the horizontal plane and views the surface of the left ventricle from 12 different angles. Okay, so 12-lead does frontal and horizontal. Some reasons why you would do a 12-lead are all listed here. Maybe they're having abdominal at the gastric pain. Try to figure out why they're having dysrhythmias, chest pain, diabetic ketoacidosis, dizziness, shortness of breath. Maybe they've been shocked by something, electrolyte imbalance, medications, overdoses of medications, maybe right or left ventricle failure, status before and after electrical therapy, stroke, dizziness, or just somebody who's unstable. Okay, these are all reasons why we would do it. Let me see. I think you know what I'm going to do? I'm going to come back to this one and we'll watch this at the end. Okay, I want to make sure we do that. So I'll come back to that one. Okay, so I kind of made this little chart for you guys for 12-lead. Okay, so a 12-lead EKG requires placement of 10 electrodes. So it's not 12, it's 10. Okay, there's 4 limbs, which we've already learned. So the 4 limbs are the white in the right arm, the black in the left arm, the red in the left leg, and the green in the right leg. And Emily, that's where I'm sure you were getting like confused because there's so many of these, it's kind of hard to remember, but this is where we start with the leg thing here, okay? So white, right arm, black, left arm, red, left leg, green, right leg. I think that this is all, let me look here. Yeah, so in your book on 131 to 133 are all the different kind of leads, okay? But I wrote this up for you. So there's going to be 3 or 6 precordial leads. Now, one thing to consider, a lot of times if you go someplace, they may not be colored. They may all be brown or something, but they'll have letters on those. So when I say all these colors, you may walk into a place where their leads are not colored and they're all one color, but they have letters on them, okay? Okay, but for our studies, we're going to have colors. So V1 is red. It's at the right side of the sternum at the 4th intercostal space. So if you can see that on page 132, up on top there, that's your standard lead placement. So this one is the only one in a normal 12 lead that's going to be on the right side. V1 red is the one that's on the right side of the sternum at the 4th intercostal space. Okay. Now, right directly across it, so you bump over your sternum and you go to V2 yellow, and you're going to place V2 right across from V1. And if you can see in the picture, more or less, the rest of them are all going to be on that side. Okay. Then you have V3, which is the green. and it is between V2 and V4. Now, I made a note here. It suggests that you actually place V4 before you do V3, and it will be easier for you to figure out where to put them. So if you look at the picture, V4 kind of is right under the nipple line, okay? And then that way you could place your V3 right between V2 and V4. But you'll get your own technique once you get it going, but that's just an idea. All right, so your V4 is at, again, it's on the left side, it's at the 5th intercostal space, mid-clavicle line, okay? Now, the V5, which is orange, is at the 5th intercostal space, and you're just starting to move back towards the underarm. So if you look at all those, the V4, V5, and V6 are all in the 5th intercostal space, and we're slowly moving back around the rib cage. Okay? All right. So essentially, your V6 is kind of almost right underneath the underarm. Okay. When you read a 12 lead, like if you're looking at the tracing, and if you read it from left to right, it should be continuous. So make a note of that. All right. So again, you can just look in your book there. I thought that the NHA book did a better job than the ECG book did on showing the, yeah, I did too. Okay, so horizontal plane only, okay? 6 chest leads view the heart in a horizontal plane. And this is, so this is your 1 through 6, okay? And your horizontal plane is just showing you another picture of it. I think that the one in the book is much better in an NHA. But you can see where your V1 is the only one on the right side, and then they slowly go back, okay? All right, there's your, again, this is telling you what part of the heart it views. There may be a few questions, girls, on the PCT test of what, you know, what are we looking at? But here's the picture that's in the book here on the NHA. I like it. Here's your one that's on the right. The V2 is directly across, and then the rest of them, you've got V3, which is on the intercostal 3rd space, or 4th space, I think, yep. And the rest are all here in line. Okay. Right chest leads, just showing you again. All right, so what this means, let me see if I have another one. Okay, so you have a person who has what's called dextrocardia. So instead of their heart being on this side, their heart's on the right side, okay? For this person, and again, it would be prescribed for you to do this, you would absolutely put the placement of that 12 lead the same, except flip it, okay? So that means you would only have 1 lead on the left side and all of the other ones on the right side in the same pattern. And that's what this is showing you. So in this person, there's only 1 lead on the left side and all of the other ones are on the right. So it's just like looking in the mirror and you just flip the person. And that you would only do that really if that person has the heart on the wrong side. Does that make sense? Okay. So this is what that picture is. Where does the PCT place the V5 lead? And of course, I've got your answer there, okay? It's at the anterior axillary line of the same horizontal level as V4. So really, really get into page 132 on learning that, because I did notice, like when I was looking at the mock exam, I did see some things there about that. Okay, so let's talk about the 12 lead process. Again, you're going to properly identify the patient. You're going to have them empty their bladder, like I told you. They're going to put their gown opening in the front, okay? And They do need to have their legs exposed, so you would probably have them take their pants off. Now, if they have shorts on, you might get away with it, but they have to have their legs exposed. Okay. You want to assist the patient to a supine position without pillows. Okay. Pillows may be necessary, though. Remember me telling you this. If the person has difficulty breathing, you can't lay them flat, so you may have to put them up. So if they have any kind of respiratory problems, they may need a small pillow. If they're in later stages of pregnancy, we're not going to put them flat on their back. We're going to put them on their left side, okay? Or if a person has back problems, a lot of people have difficulty in laying straight on their back, okay? So in these kind of folks, like especially if a person has back problems, you may need to place pillows under their knees. You might need to raise the bed about 45 degrees. Now, I already talked about the pregnant patient. They may need to lay on their left side with pillows between their knees. Okay, this helps with circulation and it keeps the pressure off the vena cava. Now, for the normal person, you're going to have them lie with their arms by their sides and their shoulders are relaxed. Okay, a patient with tremors, sometimes you can actually put their hands like under their buttocks or their hips to study the shaking. Or a lot of times, if you cross their arms across their abdomen area, this also reduces the shaking, and then it reduces the chance of those artifacts. Okay. Make sure, remember we talked about this, not to put the electrodes on the bone itself, maybe just below. Okay. And I talked about this already. A provider may request a right-sided 12-lead EKG if the person might have their heart on the right side, or dextrocardia. To do this, you're going to place those limbs as usual, but you're just reversing. Okay. Here's all your leads, the layout of the 12. Okay, so you've got your 1, 2, 3, you've got your AVRs, and your Vs are all on there. Okay, so those are all nicely done on page 132. All right. Which condition would require a 12 lead? So remember that one was dextrocardia. Dextrocardia, okay? We've already done this. So this is all about like how to figure out the rate. We did this earlier on, so we're not going to review this. I just wanted you to remember about the small boxes, the 6 seconds, and all that stuff, okay? All right, so we did all that. Make sure we get through. Oh, all right. So I just kind of want to refresh our memory about P waves. Okay, remember that P wave right here has that nice little arch. Okay, so it's positively on the line there. The Q is most often negative. The R is the next positive, and the S is negative. Your T wave is over here, and again, it's positive on the line. So some characteristics of a normal P wave, smooth and rounded. I don't really want to talk more, I don't want to get too detailed, but just remember that a normal, now sometimes a P wave can be deflected negatively and it be a normal EKG and it's just normal for that person, but the normal P wave is that small arch positively, okay? Here's some abnormal ones. This is normal right here. This one is kind of a bumpy. It's not a nice, it's more like a mountain. And this, rather than that just nice little, let's call that a rainbow. This is notched, okay? This one is a peak, so it's not that nice normal. And this one is inverted negatively, okay? All right, the P wave should have which of the following? Of course, positive, okay? Positive. Q waves, so Q wave, what do I want to talk about on here? Let me see about the next one. Yeah, I don't really want. Okay, so Q waves are right here. So the Q wave is a negative, right? So after the P, it's going to be the first negative. That's pretty much what I want to talk about there. The R wave is going to be the next positive deflection, okay? And it's supposed to be always positive. The S wave is the next negative waveform, and it's always negative. The RS represent the ventricular depolarization. We talked about that before. QRS complex has the longest duration and clearest onset and end. What else here? T wave represents ventricular repolarization. We already took notes on that, correct? About which one is for, okay, so I don't want to really go over too much of that, okay? All right, we did this already, but I'll do it again. Tachycardia is over 100 beats per minute. Bradycardia is anywhere under 50 to 60. P is left of the QRS, remember that, okay? They should look similar, and there's that atrial depolarization. The QRS should follow the P, okay? If it does not, this is where you're going to report that to the RN immediately. So if you've got Ps all over the place and you don't see any QRSs, you need to let the nurse know. J point is the exact point in time where ventricular depolarization stops and repolarization starts, okay? And the T is ventricular repolarization. T follows the QRS, upright, normal height, okay? Which of the following parts of the EKG waveform is the point where that was the J point, okay? So kind of read that. It's the point where ventricular depolarization stops and the ventricular repolarization starts. This is the question I said, like if you have all these P waves but no QRSs, you're going to report it to the nurse immediately. U waves, not all of them have U waves. They can usually appear in the same direction as the T wave. U wave should have a small upward curve. You'll see U waves, so it's not actually normal to have them. So if you do have them, a lot of times the person might have electrolyte imbalance, okay? I'm not going to go through any of those because we decided we're not going to really worry about all those. We do want to know that the ST elevation is indicative of an MI, okay? So if you see an elevation of ST, it could mean that the person's had a heart attack. All right, and we went through this to interpret a strip. You want to make sure that there's a P wave and it's upright. And then all this stuff, we're not going to worry about it because the machine does it for you. Okay. Here's that question. I think we've already had this on a test, but this is the one, and you're, on the EKG, if you see an ST segment elevation, that could be indicative of an MI, and you must report it to the nurse right away. All right, so let me go back to, because I want to show you if I can find it now, 71, I think. Let's see. Let's watch this 12 to make it more. See if this works. All right, girls, let me reduce you here for a second. Bear with me.